This episode is part of our Better Ways of Knowing mini-series, which we're running on this feed throughout the summer. The Better Ways of Knowing project asks how we should produce, evaluate, and act on knowledge if the goal is to continue to improve the health of populations. And in this series, we're sitting down with people who were part of our first convening to hear their reflections on that question. My guest today is Professor Katherine Keyes. Carrie is a professor of epidemiology at Columbia University's Mailman School of Public Health and the inaugural director of the Susan Lasker Brody Center for Population Mental Health. Her work spans psychiatric and substance use epidemiology across the life course. In this conversation, we discuss what it means that the entire field of epidemiology is built on group averages and why those averages sometimes fail to predict what happens to individuals, how to communicate uncertainty honestly without giving up on the work of public health, and what makes research questions worth asking. We also talk about the recent rise in mental health problems and what is and what is not driving it. Here's our conversation. Carrie, welcome to the podcast.
Thank you so much for having me.
So a big part of the conversation we're going to have today is based on some of the discussions we had during the convening, which was really, your focus on it was how do we know what we know? Are our semiological framings of some of the work we do in epidemiology, are those grounded in something that will continue to benefit the population at large versus individuals? Or what are other issues that we need to think about as we develop more tools, more data sets, more research questions when we care about improving the health of the specific health of a specific group or the health of the entire population? So I think those are the two sessions that you were part of the main discussions on. And I wanted to start with one point that you made early on, I think, in the convening that led to a lot of conversations, I would say, which was about the differences on how we do epidemiological studies, which look at the entire population. And we usually, a lot of our methods, almost all of our methods get us at averages at the population level compared to then results at the individual level. So talk a bit about that. What does that mean?
Sure. Yeah. The central framing of epidemiology as a science is that we're focused on predicting group averages. We're identifying risk factors that on average increase or decrease your risk for specific outcomes.
Yeah.
And what that means primarily is that at the individual level, it's often very hard to predict based on the averages of a group who will experience a certain health condition, in what way, at what time. So all we can say is, on average, this group has a higher risk. And oftentimes, actually, the group averages don't do a very good job of individual level prediction. The positive predictive value of any one factor is quite low. And there, I think, is where a tension comes up between what we do in public health and what we do in clinical medicine. Because oftentimes what we do in public health is say, look, I don't know who is going to develop lung cancer after they smoke or don't smoke. So we're just going to make a public health recommendation that people don't smoke, right? Because we know that smoking increases your risk of lung cancer, and we have a hard time predicting who and who won't develop that outcome. So just don't smoke. It's similar for seatbelts. It's similar for vaccines. It's similar for a lot of other types of interventions that our public health recommendations are at the group level because we don't do a good job at the individual level of prediction. However, I think the tension there is that oftentimes people will say, I know someone who smoked for 50 years and they never developed any health outcomes. Yeah. And they kind of use that to sow a seed of mistrust in epidemiological science, because you don't always see the results of epidemiological science at the individual level. And I think that is just really a fundamental misinterpretation of what the science of our field is and what the goal of public health is, which, as you said, is really about protecting the health of whole populations. And so we try to keep our recommendations on that level, but it's often in tension with individual level clinical medicine.
So then I have two questions. The first one, what's a positive predictive value?
Sure. Okay.
Yeah.
Thank you for that question.
No
So, the positive predictive value of any risk factor, for example, is that given that you have that risk factor, what's the probability that you'll develop the outcome? So given that you smoke, for example, what's the probability that you develop lung cancer? Or given that you were exposed to this environmental contaminant, what's the probability that you'll develop an outcome? And so at the population level, we can say, oh, exposure to this factor increases your risk of the outcome twofold, threefold, even fivefold or more. That actually oftentimes does not translate to a high positive predictive value, even though we can say that your risk is twofold higher or threefold higher. The probability that any one individual will develop the disease given that they are exposed to that factor is often quite low.
So then if I'm someone living right now, I have the means, there's so much data out there. There's AI, Claude Cowork helps me with a lot of my large data sets. I can get genomic sequencing in 2 days. I can buy a lot of products from China, and I think we discussed this during the meeting, and I can try them out on myself and just like individual level results. My watch tells me everything I need to know about my biology. Why do we still need population level averages? And why can't I just do that and just get the information that are relevant to me clinically?
That's such a good question. So here is where another tension arises.
Okay.
Oftentimes, when we as individuals are experimenting on ourselves, there's a whole host of reasons why our inference about ourselves might be incorrect. Um, from things like placebo effects or time varying confounding or other kinds of
Yeah.
epidemiological principles. And so we say to clinical medicine and epidemiology, okay, do a randomized control trial, right? Like if people are taking a certain supplement or a certain product or holding on to a certain diet, let's do a randomized control trial and let's randomize people to eating red meat, not eating red meat, for
Yeah.
example. Um, and what the clinical trial, the randomized clinical trial does is remove all those sources of confounding. And so oftentimes we hold up these RCTs as the gold standard of causal inference for good reason. The problem is that the randomized controlled trial gives you a group average, and that group average may not necessarily correspond to each individual's experience, as we just
Yeah.
talked about. So it could be true that a randomized controlled trial says, this supplement at the group level, has no causal effect on the outcome. But you as the individual say, I know that this helped me. And it could be the case that there's heterogeneity within those group averages and that there are some people that are helped causally by these
Yeah.
factors. It can also be true that you say, I know that this supplement helped me. And actually, it didn't. And right now, with our epidemiological methods, it's hard to adjudicate between those two scenarios. When we have, for example, a null result in a clinical trial, either that null result is masking true causal subgroups that benefit from an intervention, or no one's really benefiting from the intervention.
Yeah.
And I think that those methods are developing where we can kind of try to get at more of that individual level heterogeneity. But it is a fundamental tension in how we draw inference from the data that we gather at the group level that I think relates to this problem of inferring about individuals from data collected on populations.
I know your work is the science of it, and how can we do or really implement good methods to try to answer epidemiological questions when it comes to the health of populations. But if I can ask you just to think a bit more about the communication of what you just said,
Mhm.
how do we communicate to people in a world where we have a lot of influencers who show I used this peptides for 10 months and this is how I look right now? How do we
Right.
communicate the tension that you just mentioned to a regular person who doesn't necessarily have epidemiological training, and also have them not mistrust us? Because what I hear now, and maybe because I just spoke to a philosopher a few days ago, is that what you're telling me is if there is heterogeneity, all the language that you use from a science perspective, that means, though, you are limiting my autonomy of experimenting on myself,
Mhm.
even though you just said there could be heterogeneity. So why would you in public health do that? Why can't you just let me export all the peptides that I need to just see if it works for myself or not?
It's such a good question, and I think it kind of gets to the fundamental tensions that the field of public health has always confronted.
Yeah,
Is that it is within our role and our responsibility to make sometimes recommendations and sometimes policies and laws that
yeah,
we think keep the population more safe. But I also think that we have to be quite humble when we're doing that, on the spectrum between kind of persuasion and coercion.
yeah,
Persuasive, being I'm communicating to you, I don't think that you should smoke. I think smoking is bad for your health. Coercion being I'm going to enact policies and laws that coerce you to do things like get your children vaccinated before they go to school. Across that entire spectrum from recommendation to policy and law, underlying it is the so-called evidence base and the
yeah,
so-called evidence-based science. And I do think we have to be quite humble about the rigor of the evidence base that's underlying it. What we need to do in public health is endeavor to conduct the most rigorous studies,
Yeah.
and be very transparent with the public about the strengths and limitations of that evidence base, and do so always with an eye towards, kind of what is the least invasive way that we can protect the public's health so that we, to the extent possible, preserve individual autonomy to
Yeah.
engage in self-experimentation or engage in ingestion of products that we consider to be harmful. There always has to be that kind of balance to preserve that individual autonomy. And I think from a health communication standpoint, I have always been of the belief that we have to provide simple and accurate messages to the public that reflect the best available science that we have, being very transparent about, the rigor of that science, and always with an eye towards honesty.
Yeah.
I think that the public can in general accept contradictions when we are honest about them. And I think where public health fails is when we underestimate the ability of the public to accept nuance.
I agree. And I think I'm actually been struggling with this recently because I do think we should always communicate uncertainty. And but I wonder, especially when I talk to my students, that I shouldn't take that as saying you should just always say also then anything goes because we
Right.
cannot be sure exactly what's going to happen. Like heterogeneity is going to happen. We can't always also just say, oh, because we are uncertain, that means anyone can say whatever they want at any time. I just don't know where we land there. But yeah, maybe hopefully people who are working more on health communication can find a good space. Yeah.
Yeah, exactly. And I'm
Yeah.
certainly not a health communication expert, but I do think that that's where things like the precautionary principle really can
Yeah.
help guide us, in terms of the ethical decision making that we make as public health professionals, in
Yeah.
that we're always making decisions for the public in the face of
Yeah.
uncertainty. And so if we err on the side of, I don't want to expose someone to something that might potentially be harmful to them, then I think that we're operating from a, kind of an appropriate ethical foundation, but that doesn't mean we always get it right.
So then another area that you spoke about during the convening, but I also wrote about in the journal epidemiology, and we'll link to it. I really like that article because I had just read Kuhn's book on paradigms and science, and then you wrote a bit about paradigms and epidemiology. I think it was really interesting to me as someone who just started working on stressors and mental health. This is the field I started working on about almost 10 years ago now. So a lot of your argument resonated with me. I do have a lot of questions as a student, so I will ask you about specifics for that argument, but maybe tell us a bit about that article that you wrote. What is your argument on epistemology and epidemiology, and what do we miss sometimes when we design our research questions?
Yeah, that article was in response to a group of epidemiologists. I think there has always been this question of like what makes a good research question, especially when we're teaching our students. That's a hard thing to teach, but a really critical part of training in any science is not only the tools and the statistical models and how to design a study, but like how do you actually ask a good question? And so a group of my colleagues proposed this kind of framework for what makes not a what makes a research question have public health impact. And it was things like, well, how common is the exposure? Is it amenable to change? How strong are the associations? How solid is the evidence base? Can you make a contribution there? And my commentary was, I don't think any of those are what makes a research question have public health impact. I think that, again, to be humble, I guess, is that we have to acknowledge that our ability to ask a research question is itself embedded in the scientific thought collectives that we currently operate in, that constrain what questions we can ask and what answers we can accept as legitimate and what methods that we can use to answer them. So we all have these kind of predeterminations about what outcomes become visible to us, what questions are tractable, even things like, oh, is this amenable to change? Well, that itself is a reflection of the current thought collectives in science. And so I just raised that idea, which is, Fleck and Kuhn and these kind of scientific philosophers have talked about this. I mean, I'm not originating these concepts in
Yeah.
any way. And I think we learn about these ideas often in the classroom. We'll often take some kind of philosophy of science class and we'll be required to read Fleck
Yeah.
at some point. They have real legitimate implications for the day-to-day work of how we do our science because they
Yeah.
structure the very questions that we ask, the ways that we ask them, and the ways that we answer them. And so
Yeah.
to me, the argument I tried to make in that paper is that what makes a good research question, in my opinion, is not, is it harming the population? How prevalent is it? But it's what theory of disease has been outlined in the literature, and where does that theory strain and break? Where
Mm.
can I find parts of the explanatory frameworks that frame how we think about a problem like psychiatric disorders and what causes them? And where can I find contradictions and problems and things that I can probe to elaborate a theory or find contradictions that force us to come up with new frameworks for how we think about the disease itself. And that process, I think, to me, is what makes a research question good rather than how prevalent it is. Of
Yeah.
course, we should always be examining problems that cause significant human suffering, right?
Yeah.
But when we study them, I think asking ourselves, what problem am I elaborating in my study rather than how amenable is the exposure to change, I think takes us further in terms of actually creating actionable science.
Yeah. You use the relationship between stressors and population level mental health outcomes as an example in the convening. Can you explain more what you meant by that?
Yeah, this is kind of a classic example from psychiatric epidemiology, which is my field, which is that a common assumption when we think about what causes psychiatric disorders, things like depression, things like anxiety, other kind of common and rare psychiatric disorders as well. But I think for the audience, people commonly probably have experienced or know people who have experienced these kinds of conditions. We always think about stress and stressful life events as taken as a given that stress and stressful life events are causally related to the onset of these disorders. And we can see that in data at a population level. People who experience more stressful life events, whether that is acute versus chronic stressors, things like early childhood adverse experiences, exposure to conflict in kind of home countries, or things like divorce, interpersonal conflicts, partner violence, things like that. People who experience more of those events are more likely to have psychiatric disorders,
Yeah.
onset and persistence of psychiatric disorders. So from that vantage point, stressful life events are a relevant cause of these events. However, there are some anomalies and some contradictions that force us to rethink the framework that stressful life events cause psychiatric disorders. And so one example is African Americans in the US. African Americans in the US objectively experience more stressful life events than, say, white Americans,
Yeah.
from both levels of discrimination, economic hardship, trauma exposure. But across every different way that we measure psychiatric disorders, African Americans in the US have lower incidence and persistence of conditions like depression, whether that's through clinician diagnosis or self reports through structured diagnostic instruments. So that forces us to question, if stressful life events cause psychiatric disorders, why do we observe what we observe? And those same contradictions can be seen for other conditions and other groups as well. The theory breaks down. Something
Yeah.
else must be going on. Either it is, a measurement issue with our diagnostic instruments, or it is the limits of stress as a concept to capture how different communities experience and process adversity.
Yeah.
But either way, that provides a really fruitful and productive and progressive set of research studies that we can now provide that elaborate on the entire theory altogether.
So I have a question here, and I'll frame it with maybe just using personal experiences here. And those are anecdotes, so they should not be used as a generalized experience in public health. But the first one is, and I'm thinking about what you just said about finding anomalies. And if we're thinking about what's a good research question, the question for you is, then should a student who's thinking about doing more work in public health right now, should they think about where do I find the anomalies and focus on more and trying to understand why those cracks show up in the theory space that we have right now, or the paradigm we have, or if we're using Kuhn's framing of how science progresses or how science shifts, should we have more people building up on the normal size of things? So we have stressors now are established, and you as a student do more work on the normal size so we can see more anomalies. So I don't know, at what point do you think a field benefits from more people who are thinking more about the anomalies and moving them forward versus people who increasingly add to the normal science so we can actually see more of those anomalies? Like, at what point do we get a sense of this is where the anomalies are adding up to a
Yeah.
point that it benefits from a paradigm shift? And I'll say this for two reasons. The first one is I actually really agree, and I would love to nerd out, but maybe we'll do it at a different time, on what are the limitations of stressors, because we just finished a big study in refugee camps among people who experience violence by Boko Haram in Nigeria. And we're doing the analysis, and it seems like at the highest level of trauma, like sexual or physical trauma, it seems like you hit a wall with adding more stressors doesn't seem to add up to higher prevalence of psychiatric disorders. And this is with physicians on the ground. So this is the study we found, and we just like, it's baffling to us because the assumption there is like more stressors, more trauma always are going to have like worse impact, but it just doesn't seem to be that's the case. But the second experience I have is then we tried to publish some of this work in maybe that's our mistake, in a psychiatry journal. And the answer we got is we think and we know traumas are very important. Trauma as specifically defined in DSM. Why are you looking at stressors? Those should not be part of the conversation when it comes to psychiatric disorders. That is a response I got from a reviewer. Thankfully, it's advancing. So to me, it felt like, oh, there's like a very different space out there from like psychiatric journals where a clinician thought, why are you talking to me about like daily life stressors? You should just talk about specific traumas. So clearly the normal science there hasn't really progressed as much as I thought it would. Maybe that's our mistake. But at the same time, the paradigm we're using on more stressors, worse outcomes seems to be just breaking down at that very specific group. So where should I focus my attention moving forward if I want to advance the science on psychiatric disorders and mental health outcomes?
I would say those are big questions.
Yes.
But
as the inaugural director of a new center for mental health at Columbia University, you're going to help us answer those questions. Yeah.
Well, my opinion is that it's both and. I think that you need to have a critical mass, and that's why having things like concentrated centers with dedicated resources to provide training to large groups of students who can address things like stress, because everyone's going to have a different kind of way to get at it. I do think there's a lot of really meaningful and important work that can be done within paradigms. I mean, there are things that we can do. There are tools and capacity to change people's life circumstances, reduce their incidence of trauma, and ameliorate the effects of everyday stressful life events that we should be pursuing, right? I don't think we want to have the entire field focused on like finding the cracks in all of our theories. We should have some people be doing like, well, we know that, something's going on with trauma and stressful life events, and we need to do something about it, and we have the tools to. So I do think that it's about creating a critical mass of scholarship that is examining a whole spectrum of different progressive research programs. And by progressive, I don't mean, woke. I mean, research programs that progress towards an end. And whether that end is intervention or whether that end is theory, seeing both of those as equally legitimate and important lines of scholarship, I think, is something I fear about the direction of the field, because there tends to, and I do think this goes in cyclical waves as well, as like Kuhn writes about. But I do think that there is a tendency right now to frame questions as like, well, what's the intervention that you would do at the end of this? Well, what's the policy implication of this work, right? And in every grant application, we really need to like hammer that home. But if we really want to do actionable science, allowing scholarship that really focuses on theory, where there's not a very clear, like, this is the intervention that's going to happen at the end of this, is actually, I think, going to be what truly advances the field and gets us to, really transformative ways of improving population health, while simultaneously making sure we have a solid workforce that is working on advancing what we know now, if that makes sense. So I know that's not a very satisfying answer, but it really is about our collective whole rather than any one individual who may be interested in, interventions versus theory, but it's
as someone who came firmly from the camp of everything should have a direct, clear link to interventions, to now saying maybe sometimes we should work on theory because that's how you advance a field. That definitely resonates with me.
We got you. You thought you were going to get through.
Maybe my partner accuses me of just selling out. It's fine. It's like you. But no, it's actually interesting. Now I just use this example just because it resonates with more people who are not in academia. It's just like GLP-1 drugs. Someone just one day decided, I'm really interested in understanding the saliva of a lizard in a national park. And they got a small grant. And now, about 20 something years later, we have GLP-1 drugs. So that's not the specific what we're talking about when it comes to theory, but I'm just realizing more and more it's you sometimes should just let science move in a direction. You never know where you're going to end up, so you should not limit it. Yeah.
Well, yes,
Yeah.
yes, and I'll give you,
Yeah.
for me as well, I have found that research questions or research projects that at the time were criticized for not being policy relevant became policy relevant.
Yeah. Yeah.
When we studied back in the day, variation across states in laws that affect gay and lesbian people.
Yeah.
We were told, well, that's not really policy relevant because gay marriage will never be a national conversation, right?
Yeah.
And then 10 years later, our studies were part of the conversation about what, changed
Yeah.
those laws. So
Yeah.
I think if you're pursuing an interesting and important question, the policy relevance of it follows from the science, ideally,
Yeah.
rather than vice versa.
Yeah. No, I agree. So then what are you going to do at your center to try to push the science of psychiatric epidemiology or mental health epidemiology? So as I mentioned earlier, you have a new center. You're the inaugural director at Columbia University. And my understanding is you're going to focus on the future of population mental health science. So what does that mean?
Thank you so much.
Yeah.
We're really excited to be building the Susan Lasker Brody Center for Population Mental Health. And to be honest, I mean, I think it reflected in our conversation. I think a large part of what this center will focus on and needs to focus on is building the next generation,
Yeah.
having the resources to um, fund master's students, doctoral students, postdocs, so that they have concentrated training in their careers that allow them to pursue research questions that are paradigm changing
Yeah.
or intervention focused. And simultaneously, we've got this amazing institution of Columbia University where we have people across from the Morningside campus to the medical center campus who are interested in pursuing population mental health projects. And
Huh.
so we have not only grant programs so that people can pursue those research questions across all of our campuses, but then also providing dedicated workforces who can help people do analyses, write grants, do the work that they want to do. And then we also have a major part of our center that is dissemination and policy focused, so
Huh.
that our work is not just happening in the ivory tower, but we're working with community-based organizations primarily here in New York City, but elsewhere as well as policymakers and the media to
Yeah.
disseminate our work and make sure that the science of what we know about population mental health is clearly understood by the public.
One question I'm gonna sneak in, even though it's not really relevant, but since I have you here to the convening work is seems like mental health is gaining traction everywhere. So it's now no longer part of the academic conversation. I increasingly look at polling across the US of like what issues seems to be just of interest across ideological leanings. And I listened to a focus group recently of young Democrats, young Republicans, mental health was the top issue for both groups. So I was looking at the polling, but I also looked at the focus groups. And it seems like this is an area of interest for everyone. And regardless of what methods we use, and maybe we need to change our measurements, we keep doing national surveys in the US over the past 2 years. And it seems like mental health is either staying high or adverse mental health outcomes are either staying pretty high following COVID or going even higher. So
Yeah.
what do you think is happening there? I'm really baffled with everything that I'm seeing right now.
That is $1 million question. Why have
Yeah.
mental health problems increased in the US over the past 15 years primarily?
Yeah.
And my personal opinion is that it's not going to be one factor. There's a confluence of factors. A number of people have pointed to digital technology and social
Huh.
media and things like that. And obviously, there are a number of different lawsuits that are kind of pursuing those angles. But when you look at the population health research in terms of how digital technology and social media use and things like that are measured, you don't see a strong signal of an association. I do think that part of that is because we have not quite figured out what we're measuring. Things like time spent online is not really a relevant metric. What is much more important is what you're doing and seeing online,
Yeah.
and kind of the informational silos and the algorithmic ways that we are pushed into darker and deeper areas that exacerbate mental health symptoms. So I think that there's evidence to support the hypothesis that at least part of the increase in mental health problems is the fracturing of our kind of systems of information and this, kind of overload that especially young people are experiencing due to their digital diets. I think that there's sufficient evidence for that. However, I think that the science of social media, digital technology, and mental health remains very nascent, and that
Yeah.
much of what we know is what I would call like correlational. Well, I won't use any disparaging words. I will just
Yeah.
say it's largely correlational.
Okay.
So I think that there is much to but at the same time, when you do talk to adolescents, digital technology and social media is not the only thing. I mean, I know we tend to demonize it because we just see these young people staring at their phones,
Yeah.
but that's not the only thing going on in their lives. You have to remember that these increases in mental health problems occurred during a time period post Sandy Hook
Yeah.
when, school shootings and other violent threats in communities became much more at the forefront of students' consciousnesses, and the
Yeah.
number of not only threats in the school environment, but the ways in which that impacts people's daily lives with lockdown drills and fear, I think cannot be overlooked. At the
Yeah.
same time, over the past 15 years, we've experienced,
A lot.
a 30-fold increase in overdose. And the
Yeah.
number of kids who've lost a parent, a
Oh.
sibling, an aunt, an uncle, someone in their family to
Yeah.
a drug related death is estimated to be in the millions.
Yeah.
So, we can't just look at this one factor. And by the way, the other thing I will say is that when you look at the epidemiology of where these problems are concentrated, the social determinants of health, once again,
Yeah.
become really apparent because these increases are not equally distributed across economic groups. It's kids who are in the lower socioeconomic statuses who experience the most suffering from these disorders. So I think that there are some obvious hypotheses that we need to be pursuing about the new way that adolescents interact and take on information. And by the way, not just adolescents, all of us,
Yeah.
but
Adults. Yeah.
also we cannot be blind to the new realities that people are facing in terms of, the broader social environments that people are living in.
Yeah. Okay. I have so many questions, but I'll keep them for after the recording. Going back to the convening, we spent 2 days. We discussed a lot of things. Community engagement loomed large at the conversation itself, but I wanted to get your thoughts on, was there something there that you thought, oh, didn't make any sense. We shouldn't really focus on this topic moving forward. I'm mostly also trying to collect data as what should we do next in this project for the next 2 years? Or what was something that you came in with that you thought, okay, my mind is changed on this specific topic, or how we look at ways of knowing for mental health or for public health in general that we should be focusing on more?
I think that the 2 days was fascinating because it
Okay.
brought together people from different disciplines in ways that don't often get together.
Yeah.
And I think what I took away from it is the reinforcement of some things that I think are uncontroversial, which are
Yeah.
that, epidemiological science and population based science, when it's divorced from lived experiences of people in community,
Yeah.
is not as rigorous, right? That there has to be this pairing between the the kind of measures that we use at the population level and the methods that we use at the population level, coupled with working directly with communities. Like that is going to be the way that we actually, to get back to the beginning part of our conversation, that's where the fractures and what we think we know tend to be blown wide open.
Yeah. Yeah.
Because those assumptions can easily break down. The other thing that I took away from that conversation is, I guess, from a meta standpoint, are our universities actually structured in a
Yeah.
way that incentivize those collaborations meaningfully and
Yeah.
in a way that allow those collaborations to emerge organically? And what is the
Yeah.
future of the university in post 2026 world, and how can we
Yeah.
think differently about how a university supports those types of activities? It
Yeah.
left me with a lot of questions about that.
So one question we got back from someone who I think is very thoughtful, and they were persistent in their pushback, is they think this is a good question. We should ask about how do universities get structured in a way that engages with communities in a meaningful way. but they think it's the wrong time to ask that question. They were very persistent about that. They think if everything is under attack right now and we're saying better ways of knowing, we're talking about how RCTs maybe are the gold standards for a reason, but also there are issues, heterogeneity, population level, data averages. Is this really a good time to engage in those conversations, as there's a sense that there's an attack on what is science and everything goes? I actually wanted to get your thoughts on that. I understand where this person is coming from, but I'm not sure also like what would be a good moment to discuss how do we improve
Right.
our science.
That I haven't thought deeply about it, I'll say that. But my
Okay.
off-the-cuff reaction
Yeah.
is now is the perfect time to be
Yeah.
rethinking the way we want to do this, because the
Mm.
current way we're doing it, if we're just going to double down on the way that we've been doing science, where I think there are legitimate critiques of how we organize the scientific enterprise at the university level. If it's under attack anyway,
Might as
why
well.
not rethink
Yeah.
how we do it?
Yeah.
Right?
Yeah.
I don't
Yeah.
know. I can't see the value in closing ranks at this
Yeah.
point and
Okay.
defending ourselves. Well,
Mm.
we should be defending ourselves and defending our
Yeah.
science.
Yeah.
Also, why not try something different at this point?
Last question. So what should we do? We have this project for about 2 years moving forward. Our hope is that we have conversations. We're going to have other convenings. There's global learning that I'm very excited about. We're going to have researchers in other 4 countries tell us about some of the work they're doing and how it's different from here and what can we learn from it. What should we do to help move the conversation even slightly a bit forward in the next 2 years for this initiative?
Sure.
Okay.
I think there's so many things that you could do. I mean,
Yeah.
there's so much knowledge, at least in the convening that I was part of, there was so much
Yeah.
knowledge that was generated in that meeting that the
Yeah.
people in those 4 walls received
Yeah.
that no one who wasn't in that room will benefit from. So I
Yeah.
think part of what you are responsible for is making
Yeah.
sure that, you're doing this incredible work of gathering these experts
Mm.
and sharing this dialogue. But if it just stays in the 4 walls of that room, it's
Yeah.
really not going to have that much of an impact. But I do think if there's a way to kind of collate all of those rich discussions, even if there's not, an action necessarily that is taken from them, but the action of disseminating what knowledge was produced in these conversations, I think itself would be really valuable to the field. I know for me, I mean, I would be really invested in reading the outputs of the
Yeah.
convenings that I'm not invited to.
Yeah.
But I think that at least is the start, because
Mhm.
then you're disseminating it to others, and then, people will have jumping off ideas from those as well.
Carrie, thank you so much.
Thank you.
This episode was edited by Catalina Melendez-Contreras with marketing by Kinkini Bahadri. Complicating the Narrative is supported by the WashU Persky School of Public Health, and this miniseries is part of the Building Better Ways of Knowing project, funded by the Robert Wood Johnson Foundation. If this conversation was useful to you, please pass it along to a colleague who cares about the future of public health. Thank you for listening.